Welcome to This Explainer. If you're a radiation oncology resident currently in training, well, you already know that treating cutaneous malignancies of the head and neck is, frankly, one of the most technically demanding tasks we face in the clinic. Today, we're going to walk through the clinical rationale, the exact procedural workflow, and the patient outcomes of using a 3D milled bolus with VMAT, or volumetric modulated arc therapy, for complex scalp irradiation. It's a real game changer, and definitely an approach you'll want to master for your future practice. Okay, so here is our roadmap for today. We'll be hitting this scalp irradiation challenge, entering the 3D milled bolus, the two-phase simulation workflow, target delineation and dosimetry, and wrapping up with outcomes and toxicity management. Let's dive right in. Section 1, the Scalp Irradiation Challenge, Navigating Highly Convex Anatomy. To start, we have to look at why treating the scalp has traditionally been such a massive headache. The inherent anatomy of the human head throws a completely unique set of physical barriers at us when we're trying to achieve uniform radiation delivery. When you're on the clinic floor managing cutaneous squamous cell carcinoma or, say, an aggressive angiosarcoma, you're constantly rocking your brain asking, how do I get a homogeneous dose across this highly convex surface without creating dangerous air gaps? In the past, using traditional flat boluses or older matched-based techniques meant you were literally fighting gravity and the curvature of the skull. And honestly, that usually led to either underdosing the skin surface entirely or creating massive dosimetric cold spots. So the absolutely crucial point here is that high-stakes scalp targets demand both uncompromised surface coverage and incredibly rapid dose fall-off to protect your organs at risk. You're often trying to push median prescription doses of 60 to 70 gray right to the gross disease or surgical bed. You simply cannot afford an air gap that diminishes your surface dose, but at the exact same time, you obviously can't blast the underlying brain, hippocampus, or optical structures. It's like a giant puzzle. Moving on to Section 2. Enter the 3D milled bolus, a customized subtractive CNC solution. This brings us to the technological intervention that's basically changing the standard of care right now. Let's compare our clinical options. Commercial flat boluses, they struggle with gravity, we know this. 3D printed boluses, well, they often suffer from weird layer resolution issues, they fill space gaps poorly, and they have variable print density. But the 3D milled bolus is a totally different animal. It uses a subtractive CNC milling process. It's carved from a solid, uniform wax block with an exact electron density of 0.92 grams per cubic centimeter. For you as the treating physician, this means you get a flawless, custom-formed 1 centimeter fit with a perfectly smooth interior surface. As you can see during the digital design phase in the Eclipse treatment planning system, there are some really neat features. Look closely at the virtual bolus contour in blue. I specifically want to call out those two anterolateral indexing horns marked by the red arrows. You and your dosimetrist will actually manually add these during the virtual design. Why? Because they're going to physically lock the bolus into the thermoplastic mask later down the line, entirely preventing the bolus from sliding or rotating on the patient's head. Which brings us to Section 3, the two-phase simulation workflow, from virtual design to physical fit. Now, for your day-to-day clinical practice, let's break down exactly how you execute this workflow. It definitely requires meticulous coordination between you, dosimetry, and your manufacturing vendor. The whole shebang is split into two distinct patient visits. First up, the initial CT simulation, where you map out the virtual bolus. Then, you've got a brief waiting period of a couple days while the bolus is actually manufactured and shipped back to you. Finally, you have the second simulation where you physically lock the bolus in place on the patient. Let's zoom in on Phase 1. The patient is supine on a clear plastic Silverman headrest. And listen, during this phase, your role as the resident or attending is absolutely critical. You have to accurately place radio-opaque wires to identify the postoperative scar, the gross disease, and any at-risk areas. Once they're scanned, the external contour is expanded outward by exactly 1 centimeter, uniformly. This creates your rind structure. Then, a 2 centimeter margin is added from the field edge to guarantee you have adequate dosimetric coverage. Finally, this virtual structure gets exported as a DICOM file and sent out to the vendor for milling. Okay, fast forward to Phase 2, and let's see how this all builds into a highly reproducible setup. The newly milled wax bolus arrives at your department, and you place it right onto the patient's scalp. Now, instead of that Silverman, you swap it a Mold Care custom headrest that conforms perfectly to the posterior aspect of the bolus. Then, a custom thermoplastic mask is created right over the head and shoulders, registering directly onto those indexing horns we designed back in Phase 1. Finally, a rigid fusion is performed between the Phase 1 and Phase 2 CT scans. This allows you to seamlessly map your original radiopaque wires directly onto the brand new planning CT. All right, Section 4. Target delineation and dosimetry, VMAT coverage, and OAR sparing. With the physical bolus secured and the CTs fused, we can finally evaluate the target delineation and the resulting dosimetry. And wow, this is where the magic of combining a custom-milled bolus with VMAT truly shines. Notice how the physical setup perfectly translates into an incredibly conformal dose color wash. You can see just how tightly the dose hugs the convex surface of the scalp. Because the custom bolus essentially eliminates air gaps, and we're using multiple VMAT arcs, we're achieving fantastic target coverage right at the skin surface, paired with a remarkably rapid dose fall-off into the brain tissue underneath. Seriously, for your boards and your future treatment plans, lock these numbers into your memory. This data proves the dosimetric superiority of this method. Despite having median prescription doses of 66 gray to the target, the median brain mean dose is held to just 13 gray, and the maximum eye dose capped at 10 gray. This absolutely crushes many historical match-based or older IMRT techniques, keeping your organs at risk well within safe therapeutic limits. Furthermore, this setup achieves a stellar median dose homogeneity index of 1.07. Keep in mind, a perfect DHI is 1.0. So this metric is concrete proof that the VMAT and milled bolus combination effectively wipes out the severe cold spots and hot spots that we historically struggled with when trying to irradiate through air gaps with standard flat boluses. Section 5. Outcomes and Toxicity Management, Clinical Realities, and Survival Data. So the plan looks amazing on a screen, but what happens after it's actually approved and delivered? We have to talk about the clinical realities and the specific toxicities you need to manage in your patients. As the treating physician, you absolutely must be proactive. Get your specialized wound care nurses involved early in the treatment process. Why? Because the data shows that 27% of these patients are going to experience acute grade 3 dermatitis. The high surface dose does exactly what it's supposed to do, but man, it is harsh on the skin. The silver lining here is that with aggressive, proactive wound care, late grade 3 skin toxicity drops to just 5%. And amazingly, 0 patients in this cohort developed brain radionecrosis. Looking at the oncologic efficacy, the numbers are incredibly robust. Keep in mind, this is a notoriously difficult to treat patient population with very aggressive scalp malignancies. Yet we're seeing a 75% local regional control rate and a 79% overall survival rate at 18 months. For patients dealing with angiosarcomas and high-risk squamous cell carcinomas, achieving these kinds of local control rates while successfully preserving cognitive and optical function is a massive win. Now, a quick reality check. You absolutely have to stratify your clinical expectations and how you counsel your patients based on their baseline factors. The data is super clear here. Node-positive patients and those who are immune-compromised, like organ transplant recipients or folks with chronic lymphocytic leukemia, have drastically lower rates of local regional control. We're talking a drop from 92% all the way down to 42%. It is absolutely vital to factor these systemic issues into account when you are designing your overall treatment paradigm. So, as you gear up for your next complex scalp case, or honestly even your next chart rounds presentation, consider how mastering this 3D milled workflow can directly elevate your dosimetric precision and, above all else, your patient outcomes. Yes, it for sure requires more upfront coordination during the simulation phase, but the dosimetric conformity and OAR sparing really just speak for themselves. With that in mind, how are you going to utilize this tool to push the boundaries of what you can achieve in your clinic? Think about it. Thanks for joining me on this explainer, and I'll catch you next time.